Very good. So Mr. Murphy has kindly agreed to help us. He's diabetic for over 30 years. And I suppose as a result has vascular disease in multiple territories. He had a right-sided carotid endarterectomy done some years ago for what was an asymptomatic stenosis, but was about 90%. And that went fine. The opposite carotid is mildly stenosed and being monitored, but has never progressed, and neither one has been symptomatic. As an aside, when I'm assessing carotids, I don't ever feel the carotid pulse because it doesn't tell me anything. If a person has a stenosis, one will still be able to feel the common carotid. So if one looks at Mr. Murphy's left side, and just relax your neck there, Mr. Murphy, for a moment, I can feel a common carotid pulse deep to the sternomastoid, but that tells me nothing about the underlying artery. I can't tell whether it's narrowed or occluded. It isn't possible to feel the internal carotid as an individual entity, therefore one really can tell very little from clinical examination. So if someone has a carotid lesion, they need imaging, or a suspected carotid lesion. So that's just a healed scar from several years ago, just to complete the story of the vascular problem and its generality, I suppose. Mr. Murphy has had multiple procedures in both lower limbs for vascular disease, the first one probably being 15 years ago, roughly. And the left lower limb acted up first, and he had a popliteal endarterectomy because he had a relatively short, really calcified lesion of the popliteal which wasn't suitable for angioplasty or stenting, and that kept the left lower limb going for some years. He subsequently had a problem with the right side and required a femoropopliteal bypass graft from the common femoral artery to the below-knee popliteal, and the scars in between are where the saphenous vein was harvested. So the graft goes from here to here, and it's palpable just under the skin on the medial aspect of the knee. I can still feel a good pulse in that many years later. There's also some disease of the vessels in the calf, as one would expect in diabetes, and over the years all of the toes have been removed for gangrene, just at their bases really, so it is not quite a transmetatarsal amputation. It's a bit longer than the usual transmetatarsal, but it looks quite like that, and he has very good function and no problem walking with it. So while he doesn't have pedal pulses, his foot supply is quite good through collaterals. The foot is warm, it's pink, capillary refill is normal, it's intact with no necrosis at any of the pressure areas, and it has been intact for quite a long time. The left foot became problematic, I think, about a year and a half ago. He developed gangrene of the fourth and small toes, had developed quite severe ischemia. The foot was pale, even lying flat, and he had a left-sided femoral endarterectomy carried out and angioplasty. The wound healed quite slowly, actually. It took ages to heal, the upper part of it. The deep layers were together, so we weren't worried about arterial disruption, but you can see the scar is quite puckered and wide, much more so than the more distal scars. The neck is a different matter. The neck scars never give trouble. So whenever you see a wide scar like that anywhere, it suggests that there was slow healing, possibly with wound infection. But it did heal, and the perfusion of the left lower limb is improved. Again, it's not normal. There are no pedal pulses, but the skin is intact. It's pink, it's warm, and there's no areas of necrosis over any of the pressure areas. And if I lift up both lower limbs, I'll take the weight of those. There's a callosity here under the, I suppose, third or fourth metatarsal. There's some pallor, but there's still some perfusion. The actual digits are relatively pink. So these are limbs that are adequately but not normally perfused. And so long as they're not injured or infected, there's no reason why they shouldn't remain intact.